To thank everyone in person. We have a full house here in person today, so welcome everybody who's here online and in person. Before we begin, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which we now gather. Just a reminder to please leave your questions at the end. Please enter them in the chat. And please answer a brief survey that will be sent to you immediately after the presentation. This will let us know that you are here today. And finally, we have two speakers today, and I'd like to invite Dr. Marcel Bear, the Chief of ID, to present the two speakers coming to us courtesy of the Division of ID. Thank you.
Good afternoon, everybody. Before introducing the speakers, I just want to introduce the real concept behind this. I can tell you without exaggerating that it's been decades of ID rounds where people get together and argue about what's the best treatment for A or B. And it's also been decades of ID rounds on Thursday mornings where the fellows go through all of the literature and try to figure out the best way to treat it. And their final slide says, we need well-powered, good quality trials. And most people shrug and say, oh, well, that's never going to happen because it takes a lot of work. I've also learned over the past few years that if you want to get something complicated like that, you look at busy people like our speakers today, because they're the people who can get stuff done. The study you're going to hear about takes work, funding, team building, all kinds of activities led by Todd and Matt, Emily McDonald, and many other people in this room and around the world. So, very briefly, Todd Lee, Associate Professor of Medicine, FRQ Junior 2. He's a busy clinician in ID and in GIM. He's the teacher of the clinic, the residence clinic in ID. And despite all the clinical busyness and all the activities he does, if you go to the Division of ID website and you look at productivity over the past 5 years, he has published 192 articles in the last 5 years. That's not a typo. I have the phone, the app right in front of me. Matt Cheng, Assistant Professor, FRQ Junior 1. He rounds on the ID Heme-Onc Transplant Service. In fact, I think he gave that name, HOT, to the Heme-Onc Transplant. He's the ID consultant to Transplant Quebec. And in the 5 years since he's been onboarded, just 134 articles. So these are very busy people, and they show that they can get stuff done. And today we're going to hear from them about this insurmountable challenge that we've talked about for decades, how they went out and got the funding, made the teams, and we're looking forward to hearing the findings and also what this proposes for the future of infectious disease practice. Thank you, Todd and Matt.
Thank you very much, Marcel. So I have the privilege of starting the presentation, then I'll hand over to Matt, and then I'll get to close it out at the end. I have no real relevant disclosures, and Matthew has a few industry-related disclosures. Most of our disclosures are that we are intellectually conflicted by our belief that randomized controlled trials are the way to generate evidence for how we should treat patients in this hospital and elsewhere. So the overview of the talk over the next 45 minutes will be to describe a little bit about why Staph aureus bacteremia is a major problem, and it really is, and I want to contextualize that for you. Introduce the concept of the Staphylococcus aureus network adaptive platform trial, which was introduced here at Grand Rounds in 2022 with Stephen Tong from Australia, and then share with you the results of the first randomized controlled trial to close from this platform. Staphylococcus aureus infections cause more than 1 million deaths per year. It's the #1 bacterial cause of death. And it's a lethal disease. In Canada, there's more than 15,000 Staphylococcus aureus bacteremias per year. There's approximately a 20 to 25% 90-day all-cause mortality in people who have Staph aureus bacteremia. And it causes more deaths annually than many cancers, including gastric cancer, myeloma, melanoma, ovarian cancer, and others. We have about 100 to 150 cases of this disease per year across all of our sites at the McGill University Health Center. And while we have shown that mortality has improved in the last 20 years, and a lot of that has to do with improvements in the way we take care of patients, both in general and specifically with respect to the infection, the mortality remains unacceptably high. Some aspects of care of these patients have become more protocolized over the years and have become standardized and supported by decent quality evidence, such as the need to document that the blood cultures have become sterile, to identify patients who have microorganisms hiding somewhere within their body, to consider and strongly consider removing sources of infection like central lines, improvements in echocardiography and access to echocardiography to diagnose endocarditis and make sure that those patients are treated appropriately. And in many observational studies, the availability of specialized consultation has been associated with improvements in mortality. There are other aspects of care that are much more variable than these things. The use of diagnostics like PET-CT scan is variable across North America, across the world, and across physicians. The use of which antibiotics to treat patients for, the use of oral antibiotics in place of prolonged durations of intravenous, these are much more variable processes. And these represent random care, okay? What antibiotic you get treated with is a function of who sees you first and what they believe is probably most appropriate. And if they happen to be right, then hey, you're getting the best and most appropriate care. But you ask 100 people in a room and you're going to get 100 different answers for some of the management decisions with respect to this disease. That's random care. What we want to do is replace random care with randomized care. So random care, when we go to try and sort out whether something works, we have to make inferences based on observations of what patients received in terms of treatment and what happened to them. And these observational studies, no matter how good you are at doing them, no matter how wonderful your data warehouse is, they will always be subject to some level of bias, such as residual confounding, confounding by severity, and my personal favorite bias, the immortal time bias. Randomized care, when we randomize these decisions, allows for a systematic comparison and meaningful inferences between the groups. And this is how we learn in areas of controversy. To some extent, participation in randomized controlled trials are of global benefit to the patient's care because they're often standardized to a higher level. But there are, caveats in that the primary outcome is sometimes difficult to decide upon and to have an adequate statistical power. There are issues surrounding sample size and achievability of arriving at a meaningful result. And then patients who get into randomized controlled trials are sometimes different than the average patient we see because they've been selected to go into this study. What we set out to do in 2021 was to replace as much as possible random care in Staph aureus bacteremia with randomized care. We were part of the formation of this international platform called the Staphylococcus aureus Network Adaptive Platform Trial with infectious diseases trial leaders in multiple countries, most notably Australia, but also New Zealand, Singapore, Israel, the Netherlands, and others, and the United Kingdom. There are multiple different ways to classify Staph aureus bacteremia. We can classify it by susceptibility. So is this methicillin sensitive or methicillin resistant? We can classify it by source. Did it come from the skin and soft tissue, from a central line? Does the patient have endocarditis? Is it prosthetic valve? By clinical features, which is kind of a combination of source and other clinical factors related to the patient and how their case is evolving. Or by patient characteristics, so certain comorbidities, pediatrics versus adults, for instance. So imagine that we have an arena, and this is, apropos as the Canadians are fighting, to get into that playoff spot. I'm sorry that my team defeated them earlier this week. I can't watch the games anymore because of my blood pressure, right? I'm just going to say. So imagine you have an arena Okay, you have like the forum. Okay, so this is the old Montreal Forum. And on that ice surface, you can play a series of tournaments. You can have the Pee Wee tournament, and you can have the adult men's tournament, you can have the beer league tournament. Different teams of different compositions can play against each other. And within those competitions, you can choose the winner, and you can have these teams advance through the tournament. The tournaments have fundamental set of rules with some ability to adapt. Okay, so we're going to play non-contact because these are children, or we're going to have no touch icing. We could play with no offsides. Okay, fundamental rules are set, but there's some adaptability, and we all play on this arena. And this is what the Snap platform provided us the arena on which to play this game. And we set up a series of tournaments back in February 2022, coordinated out of Australia, lead principal investigator Steve Tong, Josh Davis, with funding from the CIHR for Canadian operations, nominated principal investigator Matthew Cheng. And this game has been played in these multiple countries over the last 3 years. And we have different tournaments. We have tournaments that apply to all Staph aureus bacteremia, where we might ask a question about duration of therapy, route of therapy, the use of advanced diagnostics. We have games where we're going to play only the MRSA get to play, where we're looking at different agents and different combinations. And we have games where the methicillin-sensitive Staph aureus gets to play, where we look at different agents and different combinations. This has been a huge enterprise. Okay, so we're running 130 sites across 9 countries. You can see that Canada has 37 active sites. The Institute is, and the McGill University Health Centre is the Canadian sponsor and holder of the CIHR funds, and we coordinate the trial in this country. But we liaise with all of these other countries, and we're opening more sites as time goes on. Needless to say, the number of contracts and documents and data points and CRFs and investigators is exponentially increasing. The initial structure was we separated it into groups of different antibiotics as a function of susceptibility. We're answering questions about whether giving an adjunctive or second antibiotic might improve outcomes, and then about changing to pills instead of giving prolonged intravenous therapy. And we're playing for keeps. This is a trial where we said mortality is what matters. And so we're going to power this trial on mortality. And so for the superiority or non-inferiority design, as depending on the comparison that's being made, and we're going to look at all-cause mortality out to 90 days. With respect to the non-inferiority questions, we did leave it open because superiority is a subset of non-inferiority. We said if it looks like there's going to actually be a winner, the Data Safety Monitoring Board can just not tell us to close, and we'll just keep running until a winner is declared. And we said that obviously there are a number of secondary outcomes that are super important, like acute kidney injury, drug-induced liver injury, and Clostridium difficile, treatment failure, and microbiologic relapse. Using the power of Bayesian hierarchical logistic regression, every 500 patients that get recruited to this trial and complete their follow-up, we have an interim analysis, and each of these matches, the score is checked, and we look to see whether someone has won the game, with winning the game being strictly defined as being 99% probability of non-inferiority. In the non-inferiority comparisons, it works out to around a 2.5% absolute risk difference, which is one of the smallest that's ever been studied in a bacterial disease. Superiority or futility. Hopefully we never hit futility, but futility. So as patients come in, you'll meet our wonderful research team. You'll meet Kristen or Vicky or Alexandra or Iman. And we screen the patients. We see, can they be on the platform? Do they meet any exclusion to play the game? Okay. And if they can play the game, then we're going to try and get them into the platform, at which time we can figure out which leagues they should be eligible to play. So can they be in the platform? Yes. Once they're in the platform, can they play in the clindamycin game? And if they can, great. We're going to randomize them 1-to-1 to adjunctive clindamycin or not. And then once we know the susceptibility pattern of the microorganism, because there's often a 6 to 24-hour delay between knowing that it's Staph aureus and knowing that it's MSSA or MRSA. Once we know that, we say, okay, great, they can play in the MSSA game. And then if the patient is lucky enough to do very well, like most patients, by day 14, we might randomize them to the oral antibiotics versus intravenous game. So recruitment has been amazing. Starting in February of 2022, as of the end of March, we had recruited 4,240 patients, which, because they can contribute to more than one randomization, is something like 6,000 randomizations. And for reference is the sample size of other major trials that have been published in the last 2 decades. So you can see that we crossed the sample size of all other trials by March of 2024. And with no further ado, I'll pass it over to Matthew to share with you the exciting results of the first tournament that has been resolved.
Thanks, Todd. I recognize that it's a bit unusual to go over some acknowledgements in the middle of a talk. But standing here, I find myself to be immensely grateful to be introduced by one of your mentors, to give a talk alongside another one of your mentors, and to talk about these results, which we believe will help a lot of people, is a privilege. So I want to say thank you to everyone who's been a part of this phenomenal adventure. All right, here we go. Let's talk about the treatment of MSSA. And basically, you have 2 big choices. The first of which would be to use an anti-staphylococcal penicillin. The reason why is that most isolates of MSSA produce an enzyme that hydrolyzes penicillin. It's called a penicillinase. And so in response to this threat, the pharmacology industry developed these synthetic analogs of penicillins that has a very stable beta-lactam ring, which resists hydrolysis from this enzyme. And so examples that you'll see would be Cloxacillin, Flucloxacillin in other parts of the world, NAF, oxacillin, Methicillin. A note that we don't actually use Methicillin in clinical practice because it has pretty bad adverse events, but we still use it in the lab as a term to denote MRSA, or a form of Staph aureus that's resistant to almost all beta-lactams. In Canada, with regards to anti-staphylococcal penicillins, we will use Cloxacillin, which is a drug that's generally given every 4 hours, pretty much regardless of renal function or other issues. The second major option you have is Cefazolin, which is a first-generation cephalosporin that has absolutely fantastic activity against the main penicillin-binding proteins of Staph aureus. This drug is usually given every 8 hours, so definitely not as frequent as Cloxacillin. And depending on the renal function of the patient, you can actually stretch that out to even give it every time the patient's on dialysis. One classic Royal College question is how often does this cross-react with other beta-lactams? And the answer is it's quite rare. It is possible, but there's a very low cross-reactivity even for IgE-mediated allergies. And so which do we use in clinical practice? Well, it depends a little bit about which staff saw the patient first. If you read major guidelines, including the IDSA, they will recommend an anti-staphylococcal penicillin, such as Cloxacillin here. And the main reason why is that there's concern for this phenomenon called the inoculum effect. What that is an in vitro, a lab phenomenon, where a beta-lactam can be overwhelmed by the high production of this penicillinase, or this enzyme that hydrolyzes penicillins. In vitro, anti-staphylococcal penicillins, like Cloxacillin, are not susceptible to the inoculum effect, whereas Cefazolin is. And so for that reason, major guidelines in North America, Europe, other places, would recommend using an anti-staphylococcal penicillin first line. And we know that patients who exhibit this inoculum effect phenotype, i.e. those with high burden infections, think endocarditis, they certainly do worse than those without. It's not clear if that's a matter of the underlying disease, the drug administered, or other factors. And so that was one of the critical questions we sought to answer. Which drug should be used for the treatment of MSSA bacteremia? Todd mentioned at the beginning that there's a little bit of randomness into how this decision is made. And a lot of it depends on the attending physician. A lot of it depends on your geography. A really nice survey was completed a few years ago suggesting that your first-line agent depends a lot as to where you're treated. So in North America, we prefer Cefazolin by and large, whereas most other places in the world actually prefer anti-staphylococcal penicillins. And we'll tell you in a minute who was right. When you think a little bit about the background data for this, we gave you the rationale why Cloxacillin could have been preferred. But at the same time, we have a fair bit of observational data that actually recommend Cefazolin. We know that it's easier to administer, generally has lower rates of adverse events. But in fact, when you aggregate all of this observational data, it actually seems to suggest that there's a mortality benefit in the treatment of these patients, even compared to anti-staphylococcal penicillins. So fantastic work done by Todd and others suggests that you even have a mortality benefit if you use Cefazolin as opposed to an anti-staphylococcal penicillin. However, there are major caveats to observational data, right? There's a real risk of confounding by severity. There is a belief that if you have a high burden infection, you should do better with clox, and these are the same patients who are less likely to do well. There may be residual confounding, and of course, there's a risk of immortal time bias. A lot of patients will start off on Cloxacillin, and if they're stable, will be transitioned to Cefazolin, and during that period of time, they're considered immortal in the setting of an observational study. And so we decided to answer the question, hopefully in a definitive manner, by performing a really pragmatic international RCT in patients with MSSA bacteremia. And we tried to do this as inclusively as possible by admitting patients with all sources of MSSA bacteremia. We had very few exclusion criteria, which we'll touch upon in a minute. And patients were randomized either to Cloxacillin or Cefazolin. You'll note that the slide says Flucloxacillin because in other jurisdictions, they use Fluclox instead of Clox. So they were grouped together for statistical purposes. Here in Canada, it was Clox, but other jurisdictions was Flucloxacillin. As Todd mentioned earlier, we really cared about the primary outcome, and we chose one that we thought would really help answer the question, which is 90-day all-cause mortality. We also looked at a whole host of secondary outcomes, including mortality at earlier time points and critical adverse events that you'd expect from either Cefazolin or Cloxacillin. So going over the key inclusion and exclusion criteria, we tried to make this, again, as simple as possible. So you were eligible if you had Staph aureus in the blood and you were admitted to a participating hospital. That was it. With regards to core exclusion criteria, if your blood culture had been obtained more than 3 days before, if you had a polymicrobial bacteremia with other pathogens, not contaminants, if you're known to be positive in the 3 days to 6 months prior, if it wasn't appropriate for the patient's condition, you were excluded from the general arena. We also had very specific inclusion and exclusion criteria for this particular tournament of MSSA. And so to be included, you needed to have Methicillin-Susceptible Staph aureus. And then to be excluded, it would be if you were penicillin susceptible. And the reason that we excluded patients who had penicillin-susceptible Staph aureus is because they wouldn't be at risk of producing the inoculum effect. And we really wanted as fair a comparison as possible. Of course, if you had allergies to penicillin to cephalosporins, or if you had end-stage renal disease, we also excluded you from this specific domain question. So we screened a lot of people. For the platform, we screened over 8,500 patients. Most were excluded, as you would imagine. And at the end of the day, we were able to recruit 2,800 to the platform to date. And we have data on the vast majority of them, over 2,600 patients. Specifically to the MSSA question, there was over 1,700 patients who had MSSA on the platform. And of these, we were able to randomize 76% of them, or over 1,300 patients, to the MSSA question. Of these, 670 received Cloxacillin or Fluclox, and 671 received Cefazolin. This is table 1. The major points to make with regards to baseline patient characteristics is that the median age was 66. Most patients were male. If you take a look at the distribution by geography, Australia recruited most patients, followed by Canada. We contributed almost 400 patients to this very specific question. Most comorbidities would be what you would expect, what you'd see on the CTU. So about a third had diabetes, 15% or so had chronic kidney disease or a malignancy or required iatrogenic immunosuppression. With regards to the primary outcome, we found that the mortality in the Cefazolin group was 15% compared to 17% in the Cloxacillin group. This represents an adjusted odds ratio of 0.81 with a 95% credible interval of 0.59 to 1.12. And that translates to a posterior probability of non-inferiority of over 99%. Importantly, it also translates to a probability of superiority of 89.8%. And the results were very similar if you looked at either an intention to treat or per protocol analysis. And when you look at key secondary outcomes with regards to mortality at earlier time points, the probability that Cefazolin is superior to Cloxacillin at 14 days is 94%, and then goes to 99% at 28 or 42 days. And we believe that these data are convincing to answer the question with regards to a mortality benefit of Cefazolin over Cloxacillin. Importantly, there were significant adverse events that were reduced in the Cefazolin arm as well, including a lower risk of acute kidney injury, lower risk for unplanned dialysis. There was an overall lower rate of serious adverse events and a lower rate of adverse events leading to discontinuation. With regards to subgroup analyses, most groups seem to favor Cefazolin the same way. One very important caveat is that we only had 7 patients with CNS involvement, and the data simply are too small there to make any kind of inferences. Importantly, is that patients with quote-unquote high inoculum infections, including endocarditis, seem to favor Cefazolin as well. Now, there are, of course, several limitations to this. First of all, this was an open label trial. It needed to be open label because this was being performed across multiple countries, multiple continents. And importantly, we did this in many community hospitals, including in Canada, who didn't have access to the type of resources we have here at the Institute, which would allow for a blinded trial to happen. We also performed some microbiological analyses for patients who entered the trial, but final microbiological studies are still pending at this time. We also have ongoing recruitment in other domains. As Todd mentioned earlier, we're looking to see whether or not adjunctive clindamycin would be beneficial, whether or not we could switch patients safely to an oral antibiotic. And so we're not reporting on these data yet, which may in some way affect these. But the truth is these patients were also randomized in a factorial way. And so we don't think there'll be significant imbalances, not enough to skew the interpretation of the results that were just presented. And so, in summary, before I pass it back to Todd, we found that Cefazolin was non-inferior to Cloxacillin for 90-day mortality for the treatment of MSSA bacteremia. We found that it was better tolerated with lower rates of adverse events, including lower rates of AKI, less need for unplanned dialysis, and discontinuation due to adverse events. The probability of superiority was 90% at 90 days, and was in fact a fair bit higher at earlier time points. We know that Cefazolin is easier to administer. It can be used safely in folks with penicillin allergy. And we would therefore submit that Cefazolin should be considered the first-line therapy for patients with MSSA bacteremia in most adults. There's, of course, a caveat that we don't have enough data for those with CNS disease, but on balance, we believe this should be the drug of choice. And so with that, I'll pass it back to Todd to bring it home.
Thanks. Thank you, Matthew. So the verdict is still out on a number of other questions from the original platform. And most notably, we want to bring the attention of people who work here at the McGill University to the concept of the oral switch randomized controlled trial nested within. We've recruited more than 1,000 patients to this trial worldwide, but we really need buy-in from Canadian sites. So whereas the rest of the world is converting about a third of their patients, 35% of their patients on the platform to early oral switch randomization, Canada is about 20% recruitment. And the most modifiable exclusion is that the treating team doesn't agree to give the patient pills. So we're going to encourage you, if you're involved in the care of these patients and there is the opportunity to randomize them, to have a little bit of an open mind, and that this trial has now gone through 2 data safety monitoring board meetings and has not been terminated. If bacteria were sentient, they likely wouldn't care which route the antibiotics took to get there on the way to eradicating them, okay? The bacteria don't know. They don't know how the beta-lactam got there. They just know that it's there at the site of infection and that it's hurting them. We are capable of feelings, and as human beings and as clinicians, and fear is a very powerful feeling, and Staph aureus is a very serious disease, okay? So some degree of apprehension is certainly recognized. What's quite interesting is when we looked at the registrational trials that have brought new parenteral drugs on the market for Staph aureus bacteremia in the last 2 decades, there have been 2 registrational trials that now have FDA-approved and Health Canada approved drugs, daptomycin and ceftobiprole. And there's a third that's under peer review that will likely lead to dalbavancin, which is a long-acting injectional agent, getting approval, or at least a note in the file that says it can be used for this indication. And you look at treatment failure, which is the outcome of registrational trials. They use treatment failure, which is a composite of being alive, not on antibiotic therapy, and not having had a microbiological relapse in a deep space, okay? So when you compare a systematic review and meta-analysis of oral therapy for Staph aureus endocarditis, all randomized controlled trials, and you calculate the 95% confidence interval around that, you can see that it is on the same order of magnitude as the agents that have been FDA approved, and they're given every day without any second thought to whether they're suitable or not suitable. So we do think that there's equipoise, because it's going to take a lot to convince the world to use oral therapy, even though there's some of us early adopters. But we do think that the existing randomized controlled trial evidence should take away a little bit of the pause of fear for treatment failure in our patients. So what's the next destination for SNAP? You know, where's the segue going to go here? This is a world-class research program, and I'd like to think that we are a world-class institute. And, you know, we've been very, very fortunate at the CIHR. We have SNAP originally being funded by the CIHR, with Matt as the nominated principal investigator, and Matthew has just received funding from the CIHR to really up the recruitment of oral switch patients in Canada with the support of the CIHR. I was successful in getting a number of nested studies for subpopulations within. So we're running a phase 2 study of combination, a different type of combination therapy, to see whether it will make sense to move to phase 3. We're running some phase 3 study of prosthetic valve endocarditis, and we're running a phase 4 comparative effectiveness study of daptomycin versus vancomycin for MRSA. In the pediatric division at the Montreal Children's Hospital, Jesse Pappenberg has received funding to open up all of the, potentially participating pediatric sites in Canada, so that we can randomize children as well. And there's a statistical adjustment that can be made to borrow some of the information from the adult trials and apply it to children, so that, rather than making non-evidence-based inferences between adult medicine and children medicine, we can make evidence-based inferences about how these treatments relate to children. We have Emily McDonald's dabigatran versus other DOACs for patients who are already receiving therapy for thrombosis or atrial fibrillation. The idea being dabigatran has a very unique anti-staphylococcal effect and destroys biofilm. I'm running a trial with clopidogrel. And then we're actually doing meta research on the platform. So Sean Ong is a joint PhD student at the University of Toronto and University of Melbourne. He works with Nick Daneman and Steve Tong. And we're doing meta research of different ways of approaching the patient for consent. So we're doing traditional consent with the 13-page tome and all of the signatures and checkboxes and legalese versus a simplified 3-page written by patients for patients consent document with the primary outcome of success at recruiting to the trial and a secondary outcome of satisfaction with the consent process. So we're looking forward to that result substantially because that, if it turns out to be positive, could make for major changes to the way we do these kind of investigator-initiated phase 3, phase 4 studies. It is impossible to run anything of this nature without a tremendous world-class team, and this is just some of the funding institutes that have funded this trial across the world and some of the logos of all of the people participating. And it is a litany of names, so it's very nice that Matthew and I get to present this here today, but this is, the work of tens of thousands of person hours and hundreds of people. I know because as they're reviewing the manuscript, I get dings on my phone for each person suggesting a change. And let me tell you, when you have 100 people editing a manuscript, it's a lot of dings on your phone. And we've had a tremendous, outpouring of support from Canada with a lot of great centers across this country and in the province of Quebec, including, as Matt said, 2 community hospitals in the province of Quebec at Saint Jerome and Cité de la Santé. And we've been just so fortunate to work with these people who've bought into the mission and have continued to recruit to this study. So with that, I'll close and open for questions.
So I have the honor of reading the questions in the chat. There's already 2 that I see. And apparently Matt and Todd will be doing rock, paper, scissors over some of them. So the first one I see is Luis Pilot wants to know, are there any sex differences in the effect sizes? And I think I just heard Todd saying to Matt, it wasn't done, but it's a good question. I think that's what I'm hearing.
Oh, yeah. Well, we thought it was a good question, but it wasn't pre-specified in the statistical plan, so we've not seen it. It certainly should be done. And if anyone's peer reviewing the manuscript, they should certainly ask for it.
Good. Next, David Rosenblatt, can you comment on the relative cost of treatment and the worldwide access to both drugs? Science looks solid, but if the difference is 17 versus 15, how do you factor in cost and access? I think this comes down to, is Cefazolin available in the UK?
Yeah, both therapies are available pretty much around the world. I believe I don't know the costs in different countries, but they're both affordable, I would say.
I mean, there is cost differences in certain markets. There are countries like the United Kingdom which have protected access to Cefazolin in a way that we haven't here. When you factor in kind of the equipment costs and the nursing costs with the frequency of administration, that may, kind of wipe some of the pharmacy budget thing. But what I'm going to tell you is dead patients stop costing your system money. So when you factor in life lost, if the mortality benefit at day 42 is legitimate, then obviously it's going to dominate any kind of economic analysis. But also acute kidney injury has costs and length of stay. We haven't looked at the data because that's much more messy with multiple health systems. Is not going to be part of the primary manuscript. But length of stay, delay, initiation of hemodialysis, the economics are going to be very interesting. And there is an international economic analysis being done with each country's perspective in mind.
All right, thanks. In our ID rounds, we traditionally ask the fellows if they have questions first, but I'm not seeing any of them putting up their hands right now. Volunteering. So we do have Dr. Janetti from cardiology who has a question.
Thank you. Really fantastic. I can't even imagine how much work you had to do to get this get this clinical trial going. So congratulations on all your work. My question to you is related to, you screened 8,000, but to enroll 2,000 something. And right at the start, you said something like 500 died, right? So we're already deceased before you can enroll them. So my question to you is do you think that there are some that are really like critically ill that sort of fall off very quickly? And have you kind of by this sort of selected the more stable ones that you were able to enroll? What's your thought on that?
Yeah. So when you look at any randomized controlled trial for these serious diseases, the patient mortality within the trial is almost always lower, right? It's almost always lower than the general population or the observational data would suggest. And that's for two reasons. One, there are people who die before the blood culture goes big. They die in the emergency department in hours, or they die in the intensive care unit. And then the next day, the lab notifies you that that's what they had. You're almost never going to be able to get those patients unless you're doing deferred consent model kind of sepsis care. And then there's the reductions in mortality that come from like the selection criteria of the patients and eliminating certain comorbidities. If you look at our mortality at 90 days at 15 and 17% respectively, this is much more close to the observational data of 25% than most of the registrational trials that have come out in this disease. So in the registrational trials, the mortality is below 10%, and the one we were most recently a part of was only 4% mortality at day 70. So I think we did a good job of being pragmatic and trying to get as many patients as possible, but you're absolutely right. How would this compare to those people who would be dead? Realistically, those people have received meropenem or they've received piperacillin tazobactam for sepsis, and not this.
Yeah.
All right. In the comment box, we have Nicole, who is applying to be an ID fellow as a means of asking, can you comment on the statistical analysis plan for the stratified analysis?
Type of infection. By type of infection.
So the only pre-specified subgroup analysis, I've gone through different phases when designing trials. I've gone through phases where I want to look at every single subgroup and every possible outcome, and then you end up like slicing the cheese into unmanageable pieces. And then there's what we decided in SNAP, which was the only thing we said that we would look at is CNS infection and endocarditis. And we pre-specified that up front. And that was what the statistical plan was written around. There's probably a happy middle ground, between both extremes here. But it was deliberately decided to minimize the number of comparisons that we were making.
Thanks. Isabel Malamé is asking, what was your experience with people who inject drugs, and how can we pave the way to include marginalized groups in other such trials?
Yeah, thank you. One of the things we're most proud of in SNAP is we tried to be mindful of particular patient groups that would benefit most from inclusion in a randomized controlled trial as opposed to being excluded. It would have been very easy to discuss patients who inject drugs and say, well, they may not be compliant, they may disappear on you. We should make our lives easier and simply not include them. In fact, at SNAP, we had the opposite approach. We had a working group designed specifically to try to foster care for these patients, to ensure that they would be recruited in the trial, they'd be well cared for. And you can imagine that by paying a particular focus on them, we actually were able to recruit a fair number of these who did quite well. And I'll take it one step further to argue that they may be the patients who would benefit the most, in the sense that they often struggle for a number of reasons with hospitalization, medical care. And if you could discharge them early on an oral antibiotic, it may be particularly beneficial to them. And so we look forward to reporting on those data shortly, stressing that this is a group that we're particularly concerned about.
Okay. It looks like I'm getting comments and reading them out of order. So we have a question. How did the need for valve surgery at 1 year compare? Do you have data on valve surgery? No data?
We wish we did. This is a really good question. We don't have any specific data on valve surgery at 1 year, other than the data that we talked about for patients with endocarditis. They seem to do quite well. And despite it being a high inoculum infection, they didn't seem to be worse on cefazolin at all.
But if I may, I will say that that's a good question, but I'm gonna use it to springboard into another issue, which is Matthew went over the results, and we didn't highlight that microbiologic relapse was numerically higher in people who received cefazolin than people who received cloxacillin. You know, as an ID doctor, I certainly don't want my patients to have microbiologic relapse. As a holistic clinician, I don't want my patients to have more cardiac surgery. I don't want my patients to have more C. difficile. If you are dead in the first 6 weeks, you will not get a valve surgery at a year. If you are dead in the first 6 weeks, you will not have a microbiologic relapse. And if you are dead in the first 6 weeks, you will not have C. difficile. And I think that when we go to look at longer term outcomes, we need to account for this kind of concept of statistical competing risk, in that if you do have a drug that has an early mortality benefit and you don't account for that in the analysis, numerically, it can look like you're actually doing worse on some of these outcomes that can only happen in people who lived. So if you told me there was more valve surgery at a year in the people who are on cefazolin, I would say, okay, but what if I look at that as a composite of death, or I do a survival, kind of a subhazard survival model, where I account for the fact that once you're dead, you can't have valve surgery?
We finally received a question from an ID fellow. David Lazary is asking on the theoretical reason. Thank you to the fellows in this room for giving David the opportunity. The theoretical reason why the addition of clindamycin or ertapenem or rifampin or anything else might or might not help.
Yeah, that's a really good question. Each one of these agents has a different rationale as to why it could be beneficial. Clindamycin at a high level could be particularly beneficial in high inoculum infections where there's a risk of the eagle effect, in that some bacteria may not be actively replicating, therefore beta-lactam may not be particularly effective. In contrast, a ribosomal agent like clindamycin would be beneficial. Clinda also has the theoretical benefit of being, quote, an antitoxin, antimicrobial, which could provide some benefit as well. Ertapenem, in contrast, could help saturate other penicillin binding proteins and really allow for a highly bactericidal activity when given in combination with cefazolin. The truth is that all of these theories I'm giving you are just that. They're theories. And that things that look good in vitro or even in silico don't always pan out in vivo in patients. And that's why we need clinical trials to test them. And it isn't as simple as saying that, oh, well, is there potential harm? Is there potential benefit? Why don't we just do it? And I'm speaking from experience here, because this isn't our first Staph aureus trial. It's actually our second. The first one we completed when I was a fellow here, where we added daptomycin to either cefazolin or cloxacillin in the treatment of Staph aureus, thinking, well, probably not going to make things worse. But actually, maybe it did. Maybe there was a trend towards an outcome we didn't particularly want. And so whenever we are adding antimicrobials, we really have to be careful, because they carry risk. The same way that two antimicrobials together can be more synergistic in terms of activity, they can also be more synergistic in terms of toxicity. And it's important to test these questions thoughtfully in a randomized fashion.
All right, there's still a few minutes, and if the fellows don't want to ask a question, I'm going to, Dr. Flagel, come up to beside Nadia here, and there's a microphone to pick up your voice.
Thank you. Acknowledging that we're dealing with bacteremia, is it no longer to be done to consider the tissue penetration of the agents being considered?
I think that's a really good question. And in most cases, I think it's okay, with the exception of CNS disease. I think that's one infection subtype where the data simply aren't there yet. There is ID folklore that in CNS infections, you should use cloxacillin or an anti-staphylococcal penicillin for better CNS penetration, although we may have different views on that one question. What we can say is that in this trial that randomized so many patients, we only had 7 with CNS disease, and that is simply not enough to make any inferences on that. And so be very curious for the audience's thoughts on this one, but we don't believe that the answer has been definitively obtained for CNS infections, and that the tissue penetration in that site for Clox and Cefazolin, I think, still leads to some questions as to which is the preferred agent to use there.
I have a kind of a practical question and then a slightly bigger picture question. Matt, in your talk, you said the eligibility is people who have MSSA in blood cultures. Does this exclude people with the isolated blood culture? And if you use plural, do you mean plural bottles or plural samples? Because we're going to keep on seeing people who have one positive bottle, and I think the doctors in the room want to know what to do.
Yeah. Thank you. I'll take this as a public service announcement. A single Staph aureus in a single bottle is a real problem. You don't need multiple sets. You don't need multiple bottles. One Staph aureus, one bottle gets you into SNAP, gets you an ID consult, and should be respected as a problem.
Good. Thank you. Just wanted to make sure that that S at the end of the sentence didn't leave people the wrong message. I was following along on Twitter, now known as X, on the weekend, and I understand that the pen susceptible data were also presented. So that, in theory, by comparison, allows us to ask if it went up from 15 to 17 because of the Clox, or if it went down from 17 to 15 because of the Cefazolin, if you know what the number is on the pen arm. So which is it? Is Cefazolin better or Cloxacillin worse? You think that? That's you.
Yeah, so we were debating that on the way over. So thanks a lot for that question. I don't think it's knowable. I will tell you, because it's in the public domain, that the penicillin-susceptible trial, the mortality of all of these 4 groups was highest in the Cloxacillin group. It's important to recognize that the penicillin-susceptible trial stopped because the methicillin-susceptible, the MSSA trial stopped, okay? So we hit a trigger for non-inferiority in MSSA. The Data Safety Monitoring Board saw that. They said, you should stop. They saw the increased acute kidney injury with Flucloxacillin. They saw that that was also present in penicillin. And they said, this is not a comparison you should continue to be randomizing to. So whether that mortality at the time we stopped PSSA, was during a streak or a fluke, and whether it would have regressed to the mean, we will never know. There is a project. We're going to use individual patient data. We're going to use kind of the most advanced statistical methods to make inferences between penicillin and cefazolin, but currently it's not known. And I don't know that you can tell the difference between cefazolin reduced mortality and potentially cloxacillin increased mortality. Increased mortality how? Now you could say acute kidney injury is bad, but we used KDIGO 26.5 micromoles or greater increase or change in urine output. You could say initiation of temporary hemodialysis is bad. That was only a couple of percent. I will say once you see creatinines go up, all sorts of other crazy things happen in the hospital. So like people's cardiac meds get stopped, right? Their valsartan or their Entresto gets held. Their diuretics get held. Someone decides to water the plants. And like a liter of Ringer's lactate goes in. That discharge that was going to happen doesn't happen. They need a CT scan with contrast, but now radiology won't do the contrast, so you don't answer the question. You don't get the definitive management. There's a lot of stuff that happens when the creatinine starts wiggling. And how you could separate that from all of those downstream physician and pharmacy and radiology and system consequences from the Clox, I couldn't tell you. Why I think it's the drug is a benefit is because of the early mortality difference. So we did a study where we took every paper that's looked at attributable mortality, and granted it's hard having read death certificates to know exactly why someone died, but if you do your best to decide whether they died of Staph aureus or not, early deaths, there's much more agreement that they're related to Staph aureus, and late deaths, meaning like after 45, 60 days, it's much more likely to be related to something to do with the patient, like why they had Staph aureus bacteremia in the first place. So the early mortality benefit that then kind of washes out by 90 days, I think, is you get the catch-up deaths of people who might have died of another reason. So that's why I think it's probably Cefazolin benefit.
Matt, are you going to agree or disagree?
You can disagree if you want.
No, I agree on this one, but I'd also add that it'd be really nice to answer the question if for penicillin-susceptible Staph aureus, we should use penicillin or cefazolin. Now, I know that in this audience, we'll say, well, does it really matter? Cefazolin's a better drug intravenously, easier to give. You don't need to worry about lab testing, and you'd be right. But what about at the time of discharge, if you want to give someone some pills? Then your option would be cefadroxil, probably, or amoxicillin. I mean, amoxicillin is awesome. You get super high levels, it's well tolerated, and I think in those patients, they could really benefit from knowing if it's penicillin susceptible and if penicillin's a better drug or not. So yes, I believe in cefazolin. We are, as Todd mentioned, doing an analysis to impute the data and see if statistically we can figure it out. But I still think that this is a question that should be answered and that there'd be benefit in doing so.
Thanks. So we got one more question from Steve Grover. First of all, extraordinary congratulations. Amazing. Do you have an exit strategy when it's time to move past staph and to attack the other pathogens of global interest? Like, I think he says, like Mycobacterium tuberculosis.
I'm gonna leave the
Yeah, is that what you wrote? Yeah.
So so thanks, Steve. I hope you're reviewing for the CIHR, where we have our proposal to add Enterococcus, which is another large gram-positive pathogen, onto these 105 sites and start to answer questions related to Enterococcus, which drugs should be preferred, how long to treat, whether you can use pills, similar kind of vein. To do the first randomized controlled trial ever in enterococcal endocarditis and address whether aminoglycosides should or shouldn't be used. So that'll be exciting. Our Australian colleagues just got funding to load Group A Streptococcus onto the platform. So we see SNAP as morphing into a more gram-positive organism agnostic set of arenas, plural.
Thank you. So on that final tone about the arenas, I'd just like to point out that when Todd put up earlier a picture of the forum, it was between Atwater and Lambert-Closse. And that's the year that I finished my ID training. And so it's good to hear that we're now in the Bell Center era and there will be many more arenas around the world to continue this great work. Thank you both.